All right, guys, Chapter 6 is going to talk about the measures that healthcare organizations use to report their performance to CMS. One of those being the Case Mix Index, which I know I mentioned before. This is what shows the patient population that the facility serves. CMS created the case mix methodology when they developed DRGs. They kind of work together in reimbursement. So we're going to go through that today. So a case mix index, or CMI, you need to know that abbreviation, by the way, is a description of a patient population based on certain things like age, gender, type of insurance, diagnosis, risk factors, what treatment they received, and what resources were used. Okay. Every facility is going to have a different CMI, and these are the questions they use to determine their CMI. Who are your patients? So this is where they answer age, gender, race, ethnicity, and this ties into the next question. Where do they come from? What zip codes do they live in? Where do patients that transfer to your facility, where are they coming from? Okay, then the next three questions kind of all go together. What are your patients' admitting diagnoses? When are they admitted, and who's admitting them? So these can give you an idea of the top diagnoses that your facility treats. So you can see what resources and services you'll mostly be needing and doing. Also, do we see more people during a certain time of year, like in the winter during flu season, or are most patients admitted at a certain time of day? Which can show when they're admitted, can also show if people are being readmitted after certain conditions. That would mean that they're being discharged too early. And who is admitting shows who are the top doctors that admit patients at your facility. Okay. What happens to your patients while they're at your facility shows what procedures and services are being done most frequently. So it'll identify like the top surgical DRGs and APCs, right? We all remember what DRGs and APCs are, right? Who pays for your patient's care? So this shows the payer distribution. Is it mostly commercial insurance or self-pay, public insurance? If they're getting paid mostly by one type of insurance, they can focus on negotiating, that specific managed care contract. So they're getting higher payments from their most used company, if that makes sense. And where do your patients go when they are discharged? So are they going back home? To a nursing home or rehab facility, okay, things like that. So they're answering each of these questions to get a full view of what population the facility serves. They use this information to then try to budget for what they think their expenses and revenue is going to be, and just to plan for the future. They can also use this information for staffing purposes. So if they're usually seeing more patients in the afternoon, they're going to make sure the afternoon is adequately staffed, more so than the morning or overnight. Okay. And I think I said this already too in a previous chapter, but administration is really looking at case mix index to see how complex their patient load is, so that they can plan to have enough resources for them and get an idea of what their reimbursement is going to be. Doctors are looking at it to see what conditions they're mostly treating and how complex the care is typically. And then the next slide, I'm going to talk about how CMS uses it. Okay, how do we calculate case mix index? We add up all of the diagnosis-related group relative weights, the DRG relative weights, and divide that number by the number of Medicare cases. That gives us the average relative weight. So that tells us the case mix index is the average DRG relative weight for the hospital. Okay? CMS uses this number to determine hospital reimbursement rates for Medicare and Medicaid beneficiaries. So a higher case mix index means the hospital has treated a lot of complex diagnoses or patients that use a lot of resources. So they're going to be reimbursed at a higher rate, right? Now, if you remember, relative weights are determined by CMS and they're applied to all DRGs and APCs, the ambulatory payment classifications. A little refresher on that because I know it can sometimes be confusing, but you need to know this. So stop and make a note of this. DRGs are used to determine reimbursement for inpatient acute care hospitals and are based on ICD-10 CM diagnosis codes. Okay, APCs are used to determine reimbursement for outpatient hospital services and are based on CPT and HCPCS codes. Okay, you need to know the difference between those. Okay, so again, CMS assigns a relative weight to every DRG. If a hospital knows the number of DRGs or APCs for a specific time period, like a specific month, then they can calculate the relative weight by multiplying the relative weight by the total number of cases in the DRG or APC. Okay, I am a very visual learner, and all of that is kind of confusing, so I thought it'd be helpful to show you what I'm talking about. All of these numbers are obviously made up. I just wanted to use like simple numbers to make it easy to understand. So let's say CMS has assigned DRG-A a relative weight of 1.5. That DRG-A has 5 cases in it. You would multiply 1.5 by 5 to get a total relative weight of 7.5 for that DRG. Okay, then we have DRG-B. It has a relative weight of 1 with 8 cases in it. So 1 times 8 equals a total relative weight of 8 for DRG-B. Okay, so then we go back to the formula that was on the previous slide, the case mix index. So that CMI equals the sum of all DRG relative weights divided by the number of cases. So we would add 7 from DRG-A and 8 from DRG-B, which gives us 15. And then we divide 15 by the total number of cases in DRG-A and B, which is 5 plus 7. Okay, plus 8, right? Did I do my math wrong? I did do it wrong. So 5 plus 8, which is 13. Oh no, my math's right. Okay, disregard that. Sorry. So total number of cases would be 5 plus 8, which equals 13. So 15 divided by 13 equals 1.15. This is our case mix index. Okay. Now, there are hundreds of DRGs. And each DRG can have hundreds of cases in each one. All right, so the hospital's taking the sum of all the DRGs divided by the total number of all those hundreds of cases. Okay, so I hope this helped kind of simplify it, but if you're still confused about it, just email me and I can try to walk through it with you. Okay. If administrators are monitoring the case mix index each quarter, then they can look at and explain patterns or events that affect the case mix, like during flu season or if there's a natural disaster like a hurricane or something. If they can also see the patient's length of stay, then they can really get a good picture of their facility's activity. Other things that can affect CMI are changes in services. So if they stop offering a certain procedure that they did a lot of, then obviously that's going to affect that number. Accuracy in documentation and coding and DRG or APC assignment will also affect that number. Okay. When a condition is considered present on admission, that means the patient had this problem when their doctor ordered their inpatient admission, okay? That means it also includes any conditions that develop, like if the patient is in an outpatient encounter, like in the ER, during observation, in outpatient surgery, okay? Because all of those settings are not part of the inpatient admission yet, right? The reason this is so important is because the Deficit Reduction Act of 2005 made it to where certain hospital-acquired conditions that could have been prevented would get a decreased payment. So if the patient does have one of these conditions present on admission, or POA, then this designation will prevent the payment from being penalized. And I'll give you an example. If someone comes into the hospital with a staph infection, they will designate it as present on admission, so they'll get full payment on this, right? But if a patient is admitted to the hospital and then develop a staph infection, this is something that could have been prevented, so they'll not get paid for this. Okay, so it's a very important thing that the hospital, has to indicate. There are POA guidelines that go into a lot more detail, but the gist of it is that claims are required to report conditions that are present at the time of admission, but there's no required time frame that the doctor has to document this condition by. Because sometimes someone is admitted with symptoms and they don't really know what the problem is until they do some testing, right? But once they figure out the condition and document it, then it needs to be notated as present on admission. Okay. A POA indicator is assigned to all principal and secondary diagnoses and the external cause of injury codes. So these are pretty self-explanatory. Y is for yes. Yes, it was present at the time of admission. So payment will be made for the condition. N is for no. It was not present at the time of admission. So they're not going to receive payment for that condition. U is for unknown, meaning there's not enough documentation to determine if the condition was present on admission. And then W, no payment is made for that one, by the way, if a hospital-acquired condition is present. W is the only tricky one to remember. This is for clinically undetermined, meaning the doctor wasn't able to figure out if the condition was present on admission or not. Okay, payment is made with this indicator. So maybe you can remember W is for the doctor wasn't able to figure it out. I don't know. Now, on the flip side of present on admission conditions, we have hospital-acquired conditions. So this designation was CMS's first attempt to match payments with quality of care, right? Instead of just trying to get as many patients in and out of the door as possible, we want to make sure patients are being treated with the best quality of care. This was also part of the Deficit Reduction Act of 2005, which said that the Secretary of Health and Human Services had to identify which conditions are high cost, high volume, or both, which would result in a higher DRG group because of this condition being a secondary diagnosis, and which conditions could reasonably be prevented, okay? Before they had these POA indicators, there was no way for CMS to know which conditions the patients already had and which they developed after being in the hospital. So there was no way for them to adjust payments for any hospital-acquired conditions. Currently, there are 14 categories of HACs. You don't need to memorize them, but just to give you an idea of some, what kinds of things this would include, it would be things like a foreign object being left in a patient's body during surgery, right? That definitely can be and should be prevented. A fall that causes some sort of problem, contusions or something. Surgical site infections, blood incompatibility. So that's giving someone the wrong type of blood. Okay, all of these things can be prevented. Okay, once an HAC is noted on a claim, that condition will have no impact on the MSDRG assignment as a complication or comorbidity or major CC, meaning the hospital will not get paid for it, even though they're having to use resources to treat the condition. So this really incentivizes hospitals to try to give the best quality of care so that they don't have to do any of this work for free, right? In 2010, the Patient Protection and Affordable Care Act created the Hospital Acquired Condition Reduction Program. So it's a Medicare program, and it does exactly what its name says. So it encourages hospitals to use these best practices when they're treating patients to reduce the amount of hospital-acquired conditions. So this program made it really important that hospitals notate any conditions that are present on admission, so they're not penalized as though it had developed during the hospitalization. CMS does collect this data in real time, but the penalties or the reductions in payment don't take place until several years later. Okay. All right, hierarchical condition category coding is a risk adjustment prediction model that CMS created to reimburse Medicare Advantage plans. Okay, that's Medicare Part C. So what that includes is Medicare's Part A and B, and then also things like prescriptions, dental, vision, etc. Okay, so this is only for Medicare Advantage plans. Each HCC is a list of ICD-10 CM diagnosis codes that are assigned a risk value based on the patient's health, right? So their principal diagnosis and any coexisting conditions, okay? So each patient has this HCC, this list, right? To get this list, all of a patient's conditions are organized by body systems or disease process, okay? Then it's further subdivided into condition categories based on things that cost like similar amounts. And then it's even further divided. The final HCC list has only the really severe diagnoses that are going to impact the patient's long-term healthcare costs, okay? So in this final group, this group of very severe diagnoses, the most severe condition is used to calculate the risk score for the patient, okay? This calculation happens when CMS or its designated MAC, remember those are the private groups that can bill and do these things for CMS, receives all of the diagnoses for the patient for the entire calendar year. Okay, they're looking at everything that happened to the patient during that year to calculate the risk score, which is called a risk adjustment factor, or RAF. So this number is going to go up or down depending on what diagnoses are submitted on claim forms, during the calendar year. So if a patient has a chronic condition one year, so in 2022, but in 2023 they do not have that chronic condition, then their RAF for 2023 is going to go down, okay? The program does collect demographic information about the patient, so social determinants of health, where the patient lives and works, and their education and literacy level. All of this is taken into account when they're calculating risk. So why are they collecting all this data, and why are they calculating this RAF? They're using it to try to estimate what the patient's cost will be over the calendar year. How much are they going to have to likely spend to treat this patient? Okay, life-altering chronic conditions are the most challenging when it comes to proper HCC documentation. There needs to be a lot of documentation on these to get the most reimbursement possible for the doctors in the hospitals. Examples of life-altering chronic conditions would be things like congestive heart failure, COPD, cancer, rheumatoid arthritis, things like that, diabetes. One reason it can be challenging is because there are a lot of combination codes that can be used to classify two diagnoses together, or a diagnosis with an associated symptom or complication even. Also, sometimes it's hard to get doctors to thoroughly document a patient's diagnosis and everything associated with it so that the coder can properly assign all of the codes, okay? If they don't document everything, the coder can't code everything. So then the hospital or the doctor won't get paid for everything, okay? It's as simple as that. So generally, the greater the number of chronic conditions a patient has, the higher the HCC. Patients that are healthier than average have an HCC score below 1,000, and if they're less healthy, they have a score above 1,000. Okay, and the last bullet there, because thorough documentation is so important, doctors are really encouraged to use the MEET acronym for supporting documentation. So MEET stands for how the physician monitored signs, symptoms, and the progression of the disease or of the diagnosis or regression of it. E is how they evaluated or reviewed test results, medication effectiveness, how the patient's responding to treatment. A is how they assessed the patient by ordering tests, how they discuss and review the patient's records. And then T is for treat. Did they make referrals, order medications, plan surgery, therapies, etc.? Okay. All right, commercial risk adjustment was also created by the Patient Protection and Affordable Care Act of 2010. It was implemented in 2014. So this type of payment model is for people or small groups that purchase insurance through a health insurance marketplace. Remember, we talked about these a few chapters ago. It's designed to be a risk stabilization program. So what that means is that each plan will have an average risk score that is calculated depending on the patients in each plan. So if a plan's risk score is higher than average for all the plans in their state, then that plan gets extra money. So let me break that down even further. So the plan is going to have this big group of patients in it, right? They're going to look at all of those patients' risk scores and take the average of it. So if Plan A has an average risk score of 1, I'm just making this number up, and then Plan C has an average risk score of 3, okay? The Plan A with the lower risk score than average is going to pay an extra fee. Whereas Plan C with a risk score of 3, a higher risk score than average, they're going to get extra money. Okay, so the plan with the lower risk enrollees will help pay for the plan with the higher risk enrollees. Okay. Next one is the Medicaid Chronic Illness and Disability Payment System, CDPS. This is what the state uses for Medicaid beneficiaries that enroll in a managed care organization. So this is a different type of payment model that also uses risk adjustment. It's just specifically for patients with Medicaid. This uses a crosswalk to assign certain diagnosis codes to an HCC. and then computes a risk score. So CDPS also includes less common conditions that are seen a lot in disabled Medicaid beneficiaries, but that are also very costly conditions. Also, prescription use does affect a person's risk score as well. So this method, CDPS, uses both the diagnosis code and the national drug code to determine the risk score. Okay, and the last thing in this chapter is predictive analysis. Data mining is defined as, the use of data, statistical algorithms, and machine learning techniques to identify to identify what they think will happen in the future based on what has happened in the past. Okay, and that's basically what healthcare analytics is, using data to help make business decisions in healthcare. So maybe they can see from data, if something wasn't cost effective in the past, then that way going forward, they're not going to keep doing it that way. Okay. All of the payment models I talked about in this chapter are based on data-driven metrics, right? Data that measures the quality and the efficiency of doctors. So predictive analytics is the way to give more accurate forecasts or predictions, right? To use evidence-based treatment protocols. Meaning, you have evidence from past treatments that this worked. So we're going to keep doing it this way. This will be the protocol. Or the opposite. We have evidence from past experience that this protocol did not work. So we're not going to use this one. The goal is to improve patient outcomes, right? We're always striving to improve patient care, right? Right. All right. That is it for chapter 6. I'll see y'all next time.